Your patient is in septic shock. They're on norepinephrine at 15 mics per minute. Their heart rate is 92 and their MAP is 52. The resident looks at you and says, should we start another vasopressor? What's your next move? What should you start? This is where the physiology matters more than pump settings. I'm Danielle, a critical care nurse practitioner. We're going to talk a little bit about vasopressors so that you'll know what vasopressor to start and when. Every vasopressor works by pulling on one or more of the receptor pathways. If you understand the receptors, you'll understand the drugs. Alpha-1, vasoconstrictor, increases SVR and increases MAP. Beta-1 increases contractility and increases heart rate. Beta-2, lungs, bronchodilation and vasodilation. We don't want this as a vasopressor. V1, vasoconstriction, vasopressin pathway. This is your framework. Everything else plugs into this. Norepinephrine is first line for distributive shock and septic shock because it gives strong alpha-1 vasoconstriction and mild beta-1 support. When should norepinephrine be first line? Septic shock. Patients are vasodilated with a low SVR. Vasoplegia after anesthesia. Neurogenic shock because you're going to need that alpha for the vasodilation and you're going to need some beta because their heart rates are generally low as well as their contractility. And cardiogenic shock for the alpha-1 and the beta-1 activity. With the alpha-1, it'll improve organ perfusion, and that beta-1 will help with contractility. But remember, while norepinephrine is first line for septic shock, neurogenic shock, cardiogenic shock, high doses of norepinephrine can cause tachycardia because of that mild beta-1 effect. So if you have a patient who's extremely tachycardic on high doses of norepinephrine, 25, 35, 45, 50, think in mind that norepinephrine can be the culprit. This is where you would add other vasopressors. Let's talk about vasopressin next. Vasopressin acts on the V1 receptors of the smooth muscles to help with vasoconstriction. It acts completely outside of the K-catecholamine system, so that's why it's so powerful when norepinephrine starts climbing. Vasopressin is so effective. It does have a ceiling effect. Increasing the dose does not increase the effect. This drug can be used in situations like septic shock or whenever norepinephrine is climbing or the patient does not appear to be responding to norepinephrine. It's also good in patients with liver failure who have cirrhosis and severe vasodilation because these patients typically have low SVR and high cardiac output, which makes vasopressin extremely effective. When is vasopressin not the right choice? Patients with bradycardia-driven hypotension, hypovolemia, and obstructive shock. Let's move on to epinephrine. Epinephrine hits every receptor, alpha-1, beta-1, and beta-2. This is the Superman vasopressor, but you need to know when to use it. Alpha-1, increase SVR and MAP. Beta-1, increase heart rate and contractility. Beta-2, bronchodilation and vasodilation. This is why epinephrine is both a pressor, inotrope, and a bronchodilator. It opens the airways, it causes tachyarrhythmias, and it can also increase lactic acid. When is epinephrine the right choice? In patients with anaphylactic shock. Why? Because it's the only drug that treats everything wrong with anaphylaxis and with airway swelling and mast cell degranulation. Epinephrine is also used in refractory shock when norepinephrine and vasopressin aren't enough, because it gives you both the alpha squeeze and the beta inotropic effect. It can also be used in cardiogenic shock for pump failure. And of course, epi is used in ACLS because of the alpha-1 vasoconstriction and the coronary perfusion and cerebral perfusion during CPR. And the pearl I want you to remember here is that epi, yes, it increases lactate because of the beta stimulation, not because the patient is getting worse. It's a drug side effect, not a perfusion problem. And remember, it can also cause severe tachycardia, so use it when you need power, not finesse. Let's talk about neosynephrine next. This is pure alpha. This drug has no beta-1, no beta-2, no inotropic support, no chronotropic support. It is pure alpha to the fullest. So what does this mean for you at bedside? It means that it can worsen cardiogenic shock if you give it to someone with Cardiogenic shock, because of the pure alpha and it doesn't do anything else, it can increase the afterload and worsen cardiogenic shock. But it also raises MAP and tightens blood vessels. It can also cause reflex bradycardia. So when would you use neosynephrine? If a patient is hypotensive and tachycardic, let's say they're in AFib with RVR, they're in SVT, but they're not in cardiogenic shock, it would be a drug of choice because of the pure alpha. It's not going to affect the heart rate. It can also be used in neurogenic shock because of the loss of sympathetic tone. Post-anesthesia vasodilation also responds beautifully to neosynephrine. I also use it during intubation sometimes when I need a quick bump in the MAP. I'll give a neosynephrine push. When is it not the right choice? Cardiogenic shock, because it has zero inotropic support and that pure alpha 1 can increase afterload, worsening heart failure. Septic shock as well, because you're going to need that beta support during septic shock. And bradycardia driven hypotension, because it can cause reflex bradycardia, making the problem worse. Neosynephrine is the right drug when the heart rate is the problem, and the wrong drug when the heart rate is the problem. Think about that. Let's move on to the next section. How do you choose the right vasopressor? You have to know the physiology. Remember, low blood pressure is a symptom, it's not the diagnosis. Distributive vasodilation, cardiogenic shock, pump failure, hypovolemic shock, empty tank, and obstructive shock, blocked pump. So if a patient is in distributive shock, remember that's a vasodilation problem. You can start with norepinephrine and add vasopressin if you need. Cardiogenic shock is a pump failure and a low MAP. You can also start with norepinephrine in these patients because of the alpha 1 and the beta 1, constriction and contractility. Hypovolemic shock, the tank is empty. They need volume. Remember, at the end of the day, vasopressors don't fix the problem. They give you time to treat the underlying cause. If you understand the cause, you won't have to guess the vasopressor.